All right, hello again. All right, these are my disclosures. None are directly relevant to this talk. I think more relevant is my practice is 100% foregut and comprises benign and malignant disease, and I use endoscopic, laparoscopic, and robotic platforms. And I'm going to review the role of artificial intelligence in esophagectomy. This is a broad category that renders fear, I think, for some physicians and patients alike. So to better understand the implications of AI, I think it's helpful to define what is artificial intelligence, originally defined by John McCarthy in 1955 at Stanford as the science and engineering of making an intelligent machine. AI, though, is a broad category that encompasses a variety of concepts that focus on the review of aggregate data in order to identify trends or interactions to develop a learned function that can be applied to future situations. Within AI, there are components that include machine learning, deep learning, computer vision, and robotics. Instead of a binary approach to the incorporation of AI into surgery, I think it is helpful to view it as a spectrum. Level 0 is no autonomy, with levels 1 through 4 with progressive autonomy. Level 1 corresponds to what we see with current robotic platforms with telemanipulation, and this progresses over time to level 5. While not currently available in surgery within healthcare, an AICD would be an example of level 5. I think within surgery, the robotic surgical system is not autonomous. However, it is a promising platform with potential for progressive incorporation of AI over time. Cleared for use in 2000, the platform has grown with annual year-over-year growth of 12 to 18% in volume. It is increasingly popular among surgeons, and I think with respect to esophagectomy, we have seen that volume grow. Earliest uses date back to 2002. The robotic esophagectomy, or RAMI, is a natural platform for the incorporation of AI. Leading up to this point, there have been a multitude of institutional series, database analyses, literature reviews, meta-analyses, studies, and randomized controlled studies that evaluated the role of robot in the space. Some of the early MIS studies looking at laparoscopic and open esophagectomy included the TIME and the MIRO trials, which did show promising outcomes with respect to complications, length of stay, and blood loss, as well as pneumonia, and non-inferior results with respect to oncologic outcomes. More recently, some of the randomized controlled studies, some of these are ongoing, looking at RAMI versus MIE or laparoscopic platforms, are looking at, again, similar concepts of oncologic outcomes as well as quality of life and complications and cost. A recent systematic review evaluated the use of the robotic platform as a component in at least one, if not all, phases of esophagectomy. 85 studies, or 75%, reported a robotic-assisted thoracic phase, with 64 studies, or 57%, performing robotic abdominal and thoracic phases. A hybrid minimally invasive approach involving laparoscopic abdominal and robotic thoracic phases was reported in 17%, or 19 studies, with 4% of studies having at least some component of an open phase. Notable findings include longer operating time per RAMI, but this does improve until the 20th case and then peaks around 80 cases when maximal improvement is achieved. It is thought that the visualization and articulation offered by the robotic platform allows for diminished potential for injury and blood loss, hopefully leading to quicker recovery. The current evidence, though, is heterogeneous with a wide range in length of stay. Blood loss was noted to be less in the MIS study in 2 studies. However, the mean average was 200, though this was not broken out by phases. Complication rates, including pneumonia, ranged wildly in these studies and were likely attributable to methods of diagnosis and management. Looking at anastomotic and chyle leaks, established complication rates range from 0 to 16%, with anastomotic leaks with equivalent incidence across various anastomotic approaches. With some individual series, though, reporting these complications as high as 20%. Chyle leaks, however, were closer to 4%. Margin status and lymph node yield are the major markers evaluated for oncologic outcomes, and median positive resection margins were found to be just under 4%. Those studies noted rates as high as 10%, and these ranged across some of the European registries that we look at. Current guidelines, and this has already been discussed in this session, recommends at least 15 lymph nodes for evaluation. In the review that I discussed, this ranged from 8 to 70, and I think their variation has to do with a lot of factors from technique to pathology approach analysis. Some of the individual studies had lower levels and lower yields, so I suspect that this is reflective of experience both with the surgery and the platform, as well as variations in the neoadjuvant approaches, which was also discussed earlier in this session. I think an important note regarding complications is the Esophageal Complications Consensus Group. This is a multi-institutional international platform for developing a shared language and benchmarking complications and quality outcomes surrounding esophagectomy, regardless of approach or indication. And this is something that I think, looking towards the future for RAMI, would be incredibly helpful to develop a shared language. Also mentioned earlier in the session, I think it's interesting, is the Achilles heel of esophagectomy. It's notable, the morbidity and mortality. So where can an AI be incorporated into this platform to address these weaknesses? Options include automation, precision, decision-making, and training. We do have an ability to peer into the future with the current AI surgical models. There is the Smart Tissue Autonomous Robot, or STAR. This system out of Hopkins has been used to create an intestinal anastomosis in a pig model. It is the first robotic system to plan, adapt, and execute a surgical plan in a soft tissue model with minimal human intervention. There are other models out there that similarly have developed tasks for suturing a straightforward wound. While complex surgical steps involving dynamic environments may be a ways off, there are other more immediate tenable options for AI in esophagectomy. Computer vision is one potential area of interest where machines can gain human-level capabilities with object and scene recognition. Machines can gain knowledge from viewing images in a non-continuous manner from motion analysis, time analysis, organ or structure segmentation, as well as phase segmentation. This could be a predictive real-time tool to limit more quickly and identify adverse events. Neural networks are another option for AI in the future with respect to RAMI. This can be used for risk stratification and decision-making. As an example, with input from various components of the medical records, a layered analysis can provide a more sensitive and specific risk stratification model, as seen with pancreatitis and aortic aneurysm repair currently. With respect to MIE, risk stratification can better guide perioperative decision-making and intraoperative decision-making. Deep learning, another component recently used to break out the phases of esophagectomy. They were able to train AI for automated phase recognition. Augmented reality additionally has promise for identification of structure and to guide intraoperative decision-making. Potential considerations for RAMI also include a screen overlay that not only identifies structures, but engages the surgeon in decision-making based on real-time analysis regarding next steps and potential missteps. This type of AI has implications for decision-making, risk avoidance, structure identification, and training. From a training perspective, AI could be used to cull from a multitude of inputs regarding information of the phase, structure, and similar situations to guide decision-making. As we are increasingly able to incorporate AI into surgery, there are important conversations that we must have. One is transparency. What is disclosed to the patient? How does this impact insurance coverage, coding, and billing? What about responsibility? With progressive levels of autonomy, where does the responsibility lie? Who owns the decisions, the technical maneuvers, and the outcomes? The programmer who created the software, the company that marketed it, the hospital that bought it, or the physician who used it? Lastly, we need to be mindful of the data used to develop AI's role in surgery. Narrow data sets can lead to algorithms that are not applicable broadly. The critical view of safety challenge by SAGES is an example of how multiple data sets can be combined to create a more applicable real-world AI. To answer these questions, it's important to establish not only research to guide the incorporation of technology, but to create forums such as this one to develop a consensus and guidelines. It is through this type of meeting that we can better develop a shared language and pathways moving forward. Thank you.